Karin Thursky. I'm the Director of the National Centre of Antimicrobial Stewardship, and it's my great pleasure to welcome all of you online and all of those of you who will watch these videos later, because we'll be obviously posting all these videos onto the NCAS website. We have over 500 registrants for the week, and I think it really highlights the fact that we have lots to do to address this issue of antimicrobial resistance and antimicrobial safety. Before we kick off today, I would like to acknowledge the traditional owners of the land that we are on today and pay our respects to their elders past, present and emerging. On your screen, you'll see our Twitter handle and also the Antimicrobial Awareness Week handle. We truly love it when you tweet, and we will retweet you. I think one of the things that we have learned in this field is that social media has been incredibly powerful. I'm also incredibly excited and happy to have Professor Paul Kelly, who's the Acting Chief Medical Officer of Australia, with us this morning. He has graciously agreed to talk this morning, even though he's probably been pulled in a southern direction with the issues in South Australia. So Paul is a public health physician and epidemiologist with more than 30 years research experience. He's worked around the world in health system development and infectious diseases epidemiology, and he was one of the leads in developing the FluCan project, a national influenza surveillance system used by hospitals to track patients who are hospitalised with influenza. And this work obviously is incredibly important and will obviously influence the future issues with our COVID vaccine rollout. So thank you so much, Paul. We really look forward to hearing your thoughts around the new antimicrobial resistance strategy for Australia, and I'll hand over to you.
Thanks, Karin. So welcome everyone to this really important webinar series over the next few days. And it's a pleasure to be able to address you right from the start. Firstly, I'd like to acknowledge the country I'm sitting on at the moment. It's and the traditional owners of that land. That's the Ngunnawal people of the Canberra region. I also acknowledge the traditional custodians of the various lands on which you're located today and all around Australia and elsewhere, and the Aboriginal and Torres Strait Islander people participating in this webinar. Welcome. I pay my respects to the elders past, present and emerging, and celebrate the diversity of Aboriginal people and their ongoing cultures and connections to the lands and waters of Australia. So thanks so much for the invitation to speak, and congratulations to Karin and her team and for holding this webinar event. I'm sure everyone would agree that this has been quite a year for the health sector, and particularly for those of us interested in infectious diseases. Unfortunately, the COVID-19 pandemic has overshadowed almost everything else this year and drawn attention and effort away from many critical issues, and antimicrobial resistance is one of those issues. But AMR has certainly not been forgotten. While we necessarily have to focus on our energies on responding to this pandemic, there's been several significant positive developments in relation to AMR this year. Firstly, the new National AMR Strategy for 2020 and beyond was endorsed by the Council of Australian Governments and released in March. There it is. It's a thin document, but it's an important one, and it replaces previous documents that we've been using to guide our strategy at the national level. So it was endorsed by COAG. The COAG no longer exists, but it will still remain our blueprint at the national level to work on this issue. I know that a number of you contributed to the development of this strategy through your various roles, so thanks for sharing your knowledge and expertise, which is included in the document. The new strategy has strengthened a One Health focus and calls for shared responsibilities across health, agriculture and environment portfolios, and I'm sure Mark Schipp will talk to those other elements outside of the health sector shortly. It also references enhanced collaboration between Commonwealth and states and territories to ensure a more unified national approach to addressing AMR in Australia. So while addressing antimicrobial resistance as a whole, it recognises that antibiotic resistance in human health is still the most pressing issue to address. The strategy is available on the AMR website, which I'm sure will be referenced throughout the proceedings over the coming days. The next positive development was in May when the Australian government approved $4.65 million for the continuation of our current AMR surveillance activity during 2020-21 in the budget. And most recently in the October budget, the Australian government allocated a further $22.5 million over the next 4 years to continue that surveillance for antimicrobial usage and resistance. This includes funding to develop a One Health surveillance capability, including maintenance of our existing human health surveillance capability, a national AMR research agenda, and a monitoring and evaluation framework. The overall goal of the new AMR strategy and the purpose of the funding, which underpins it, remains the same. That's to minimise the development and the spread of AMR and to ensure the continued availability of effective antimicrobials in Australia. I thought you might be interested in learning a bit more detail about some of the key priorities the Commonwealth is progressing under the new strategy, so I'll go to that next. So in terms of One Health surveillance, this is a major development under the new strategy. It's the shift to establish a true One Health AMR surveillance system. Currently, the Department of Health funds the Antimicrobial Use and Resistance in Australia, the AURA surveillance system, which deals exclusively with AMR in human health. Over the next year, we have an opportunity to design a new One Health surveillance system. We need to ensure that we retain the best elements of our existing approach to human health, think about what improvements we could make, and ensure that the new system meets the needs of all sectors with an interest in monitoring AMR in Australia. The first task of the transition is to develop a detailed One Health surveillance plan. This will provide a snapshot of resistance and usage surveillance capacity and capability across the various sectors in Australia and propose a new One Health surveillance system. We will be consulting with stakeholders on the development of that plan in the coming months. The next stage will be for the department to procure a supplier or a consortium of suppliers to deliver the new One Health surveillance system. I suspect that under these new arrangements, those of us who deal with AMR in human health will be working much more closely with our colleagues in animal health, in agriculture, and in food production, as well as environmental areas under this new approach, which is very welcomed. And we've had already many discussions with those sectors, and Mark and I are meeting on a regular basis in terms of the animal health side in particular. The next component is the One Health Master Action Plan. Under the strategy, each sector, so human, animal, health, agriculture, and the environment, has its own particular challenges to meet. One of the priority areas for action is the development of sector-specific action plans. The Department of Health is developing a One Health Master Action Plan. The intent of this plan is to provide guidance to sectors and organisations to assist them to develop their own action plans to give effect to the objectives and the priorities detailed in the strategy. While the 2020 AMR strategy provides a long-term vision to address AMR, the Master Action Plan outlines short and medium-term priorities over the next 5 to 10 years. We need to get on with those. The One Health Master Action Plan is being developed with the assistance of a group with which some of you may be familiar and or are members of, the Australian Strategic and Technical Advisory Group, or ASTAG. It includes representatives from government and non-government organisations across human health, animal health, agriculture and environmental sectors, and provides expert advice to the government on AMR. I would encourage those in different sectors to share their action plans when they're ready on the Australian Government One Health AMR website, which I referred to earlier, amr.gov.au. I also mentioned earlier that we will establish a national monitoring and evaluation framework. This will help us better measure the impact of all of our efforts and provide greater clarity in relation to whether our actions are achieving progress and the expected outcomes. In terms of research and development, the 2020 strategy has identified areas of research, including understanding resistance patterns, best practice and strategies to minimise the development and spread of resistance, behaviour change approaches and communications to improve appropriate prescribing, the economics of AMR, as well as developing new ways to encourage innovative research for novel therapeutics and diagnostics. And haven't we seen that in action this year in the COVID space? A national AMR research agenda is a key priority, and we aim to develop a national strategic framework and prioritisation process for research over the next couple of years. Broad consultation, again, will of course be an essential part of this process, and I would welcome you all to be involved. Internationally, AMR research, and in particular the focus on reinvigorating the failed development pipeline for antibiotics through innovative funding models, gained momentum under the G20 and United Nations prior to the COVID pandemic. We need to take the time to learn from the COVID research response about how to approach collaboration and target research for shared benefit, and how this can be applied to AMR research landscapes into the future. I'll just touch on global collaboration now. The strategy also outlines the need for us to engage globally with initiatives which seek to slow AMR, particularly in our neighbourhood in Southeast Asia and the Pacific region. The Australian government has already taken steps in this area, announcing $8.3 million in June to support 4 research projects investigating drug-resistant tuberculosis and antimicrobial resistance among our Pacific Island neighbours. We also contribute to the WHO's global antimicrobial surveillance system through Professor Monica Lara's lab in the University of New South Wales, and we hope to expand the levels of data we provide over time. This system was developed to take a global perspective on AMR surveillance and research. It plays a critical role in strengthening the global evidence base on AMR to help inform international decision-making and drive national, regional and international action on this particular topic. So just to conclude, Australia has 7 national health priority areas: arthritis and other musculoskeletal conditions, asthma, cancer, cardiovascular health, diabetes, injury and mental health. These conditions have been identified as priorities because of their associated high social and financial costs to individuals and to society. While AMR isn't an obvious health condition, its potential impact makes it one of the most pressing health problems we face nationally and globally. For me, it's the next priority after COVID. I know that everyone participating in this event feels the same, and I encourage you to continue working towards and achieving our shared AMR goals. In government, we'll be using the new National Antimicrobial Resistance Strategy 2020 and beyond as our principal guide to taking action on AMR over the coming years. I hope everyone is able to align their efforts and resources to the objectives and priorities set out in the strategy, and that together we can make a difference because we really need to. Now's the time. I hope that you enjoy the remainder of the webinars this week. I am hoping to pop in when I can, although as you can imagine, things have changed a little in the last couple of days, as Karin mentioned earlier. So I do need to concentrate on the situation in Adelaide today. Thanks again for inviting me to have this opening address, and I really hope that the rest of the webinar is a success, and good luck with all of your work in the future. Thanks, Karin.
Thank you so much, Paul, for your comments. From my point of view, and those of us who have met with your team members, Lara Purdy, Tanya Farmer, who are working towards a strategy, we're really excited and enthusiastic, and we know that it is going to be a huge piece of work, but we think it's going to be really heading into the right direction. We're also incredibly grateful that we have Dr. Mark Schipp, who is the Australian Chief Veterinary Officer. He's actually online, but he recorded some comments that we'll play now. So Mark was appointed the Chief Veterinary Officer in 2011, and he was also appointed as Australia's delegate to the World Organisation for Animal Health, the OIE, where he's also the elected president of the OIE World Assembly. Mark explains the role of the OIE president and his expectations through his 3-year term, and he leads Australia's national responses to the emergency animal disease incursions. He works to strengthen the veterinary services of countries in our region so they're able to detect and respond to emerging infectious diseases of concern to both human and animal health. And he has been active in leading Australia's agricultural response to the global threat of antimicrobial resistance. And he has actually been a wonderful advocate for the AMR strategy and has presented at each of our forums, and we look forward to your comments, Mark.
Firstly, thank you to the National Centre for Antimicrobial Stewardship for asking me to participate in this webinar series. It will be an interesting week of Australian and international events. Let me begin by giving you a greater understanding of why this week is so important, not only to us in Australia, but throughout the world. Antimicrobial resistance, or AMR, is a global public health threat. At least 700,000 people currently die of resistant infections every year globally, more than the combined number of deaths caused by tetanus, cholera, and measles. There are at least 2 million infections a year caused by bacteria resistant to at least first-line antibiotic treatments, and at least 23,000 deaths a year in the United States alone. It is also estimated that by 2050, 10 million lives a year may be lost to AMR, exceeding the 8.2 million lives a year currently lost to cancer. While antimicrobial use is considered the most important factor leading to resistance, the global drivers of AMR are multifactorial in nature. These include drug pipeline deficiencies, inadequate infection prevention and control, globalization and international travel, poor or slow diagnostic capabilities, and substandard antibiotics. Antimicrobials are used in a variety of animal-associated settings, such as veterinary clinics, farms, and feedlots. Globally, there is a general scientific consensus that antimicrobial use in a variety of settings contributes to the burden of AMR, including the use of antibiotics in intensive livestock farming systems. The previously mentioned drivers have led to several major international human and animal health players working together on AMR. They are working to enhance AMR awareness and develop standards, as well as develop capacity in low and middle income countries. The World Organization for Animal Health, or the OIE, is coordinating global action on AMR. As the current president of the OIE World Assembly, I'm always keen to highlight some of the important work the OIE is doing on the AMR front. As a member of the Tripartite Alliance with the World Health Organization, or WHO, and the Food and Agriculture Organization of the United Nations, or FAO, the OIE played a significant role in developing the current WHO Global Action Plan on Antimicrobial Resistance. This plan aims to ensure the continuation of successful treatment and prevention of infectious diseases with safe and efficacious medicines accessible to all. In addition, the tripartite also developed a monitoring and evaluation framework to assist member countries assess their progress against this global action plan. The OIE has also taken the lead to build a global database to record the usage of antimicrobial agents intended for animals. The next iteration of this global database will be integrated with the World Animal Health Information System, or WAHIS, which is a system that records the animal disease information of member countries. Through this addition, the OIE will provide member countries with a greatly enhanced user interface with improved functionality. They also support member countries by providing training opportunities for OIE national focal points for veterinary products. In 2020, this included a regional seminar in Malaysia focused on veterinary pharmacovigilance and a series of online webinars designed to help member countries improve their reporting and analysis of antimicrobial usage data. As a strong supporter of World Antimicrobial Awareness Week, the OIE has developed a range of communication materials for people to access and share around the globe, which can be found on their website. I also held recent regional webinars on communication skills for antimicrobial resistance and how we can improve audience reach and engagement through the use of social media platforms. Moving to our domestic initiatives, the Commonwealth will continue to deliver strategies that are consistent with and build upon global initiatives. As mentioned by Professor Paul Kelly, the National AMR strategy aims to protect the health of humans, animals, and the environment with a goal to minimise the development and spread of AMR and ensure the continued availability of effective antimicrobials. It builds on the first national AMR strategy and opens the scope to include food, the environment, and other classes of antimicrobials, such as antifungals and antivirals. Now that the new AMR strategy is finalised, detailed sector-specific action plans are being developed to support these objectives, including one for animal health sector. We will progress this action plan with our stakeholders. Inappropriate use of antimicrobials in all types of animals can contribute to the global AMR problem. There has been a strong focus on the large-scale use of antimicrobials in food-producing animals, particularly in intensive livestock farming systems such as poultry and pigs, and aquaculture. On the issue of antimicrobial use in animals and its contribution to AMR, it is useful to reflect on how Australia ranks amongst other countries with regard to such usage. A report on antimicrobials in agriculture and the environment, reducing unnecessary use and waste, published in 2015 by the United Kingdom Review on AMR, showed that there is considerable variation in the volume of antibiotic use amongst countries. Of the countries examined, Australia had the 5th lowest level of antibiotic use in agriculture. As a result of our low levels of antimicrobial use in food-producing animals, the risk of development of AMR from animals in Australia is considered to be low. Other factors that contribute to our low risk include strict regulation on registration, high levels of biosecurity, and extensive farming systems that do not favour bacterial disease. AMR surveillance undertaken to date in food-producing animals generally supports this view, noting that there are some areas for improvement. Nevertheless, we in animal health must continue to strengthen our antimicrobial stewardship activities to ensure we have low to minimal use of antimicrobials in animals, which also does not compromise their health and welfare and still minimises antimicrobial resistance here in Australia. There are a number of antimicrobial stewardship activities that the animal health sector has been involved in, and given the Antimicrobials Handle with Care theme for World Antimicrobial Awareness Week 2020, they're worth highlighting in some detail. In November 2018, Australian Livestock Industries published the first Compendium of Antimicrobial Stewardship in Australian Livestock Industries with funding from my department. It tells readers about the long antimicrobial stewardship history we have had in animal health since 1955. This compendium is available on Animal Health Australia's website. The Australian Government also released an update of the importance ratings and a summary of antibacterial uses in humans and animals in Australia in mid-2018. It provides information and guidance to inform decision-making about the registration and use of antibacterial medicines in Australia for human and animal health professionals. I ask Australian veterinarians to pause and consider each antimicrobial prescription. Can you use a lower rating or narrow spectrum antimicrobial? Veterinarians need to familiarise themselves with our antibacterial importance ratings to help maintain the low antimicrobial resistance we have in animal health. Antimicrobial prescribing guidelines have been developed, including those for dogs and cats, pigs, and most recently poultry. The guidelines contain best practice prescribing information to help clinical veterinarians appropriately use antimicrobials by considering the 5 rights: the right drug, the right time, at the right dose, for the right duration, and the right route. To further help veterinarians make optimal decisions when prescribing antimicrobials, an online resource about effective antimicrobial stewardship practices was developed by the veterinary schools of Australia and New Zealand and funded by the Australian Government. This practical online resource is available to all veterinarians, with additional modules currently being developed by the University of Sydney and Charles Sturt University with further Australian Government funding. When these additional modules are completed, the online training course will cover antimicrobial resistance as a societal problem. How does antimicrobial resistance develop? How do antibiotics work and what is their relative importance? Drug selection and regimen, which drug is best for the patient and society? Implementing an antimicrobial stewardship program in your practice. Biosecurity and infection control in veterinary clinical practice. How do we stop transmission? What evidence supports the diagnosis of a bacterial infection? Government and industry members will also be able to access a range of other tools on the same site to assist with AMR and antimicrobial stewardship. There is prescribing support, links to veterinary prescribing guidelines, and infographics that can be downloaded and printed for use in clinic, on farm, and in schools and universities. I hope that the veterinary profession will find these educational tools an important refresher. I also want to take this opportunity to highlight some of the excellent work that our livestock industries have completed on the antimicrobial stewardship front. Many livestock industry organisations have introduced formal antimicrobial stewardship frameworks, including the chicken meat, feedlot, and pig sectors. These publicly available resources also serve as a good resource for those animal industries with less formal approaches to antimicrobial stewardship. Examples include Australian Pork Limited has a dedicated webpage on antimicrobial stewardship with a reminder of as little as possible, as much as necessary. The webpage provides useful information and links to key resources, in particular the pig prescribing guidelines. The Australian chicken meat industry has a long history of judicious use of antibiotics and implementing antimicrobial stewardship principles. The industry recognises its role in reducing the risks of antimicrobial resistance through the judicious use of antimicrobials and strategies to reduce the burden of disease. The industry has introduced an antimicrobial stewardship program that can be adapted to individual chicken meat companies. The Australian Lot Feeders Association produced the Antimicrobial Stewardship Guidelines of 2018. The guidelines provide a continuous improvement framework that formalises the antimicrobial stewardship framework for lot feeders to use. These guidelines align with the national AMR strategy and are based on the previously mentioned 5 R's of stewardship. They aim to guide lot feeders towards best practice management and use of antimicrobials. Dairy Australia recognises the need for continuous improvement in antimicrobial stewardship. The dairy industry views itself as being in a favourable position to confront the challenge of antimicrobial resistance and to support sound antimicrobial stewardship, such as through the application of the principle of as little as possible, as much as necessary. Dairy Australia recently is supporting the dairy industry to develop an antimicrobial use strategy which will align with the Australian Antimicrobial Sector National AMR Plan 2018. From a jurisdictional perspective, complementary One Health or animal health AMR strategies or policies are also in development or have been finalised in Queensland, New South Wales, Victoria, South Australia and Western Australia. In closing, I'd like to once again take this opportunity to thank the National Centre for Antimicrobial Stewardship for hosting this event and commend their commitment to tackling the global issue of AMR through their innovative and ongoing research that seeks to optimise antimicrobial use in human and animal health using a One Health approach. It's certainly a great way to kick off the World Antimicrobial Awareness Week 2020, and I'm looking forward to hearing from the rest of the speakers in the program. Thank you.
Thank you, Mark. That's wonderful, and obviously not always visible to the human health people online about the huge amount of work that is being done behind the scenes. So it's up to me now, so I'll have to introduce myself. So I'm Kaz Thursky. I'm an RD physician, Director of the National Centre for Antimicrobial Stewardship. I also have a parallel role in immunocompromised hosts and am the Associate Director of Health Services Research and Implementation Science at Peter Mac, and been involved in the CRE there with Monica Slavin around implementation. I have had the great pleasure with NCAS over the last 5 years working in a true One Health environment, working very closely with Glenn Browning, who will be talking after me, and building relationships in aged care, primary care, and even dentistry as we start to look across the improvement of antimicrobial use. So I'm going to focus today really on judicious antimicrobial use. Really challenge in Australia. Just as an introduction, this year was the first time that the WHO coined it Antimicrobial Awareness Week instead of Antibiotic Awareness Week. We actually have always called it Antimicrobial Awareness Week for many years, as we have recognised that there are judicious use issues across all classes of antimicrobials, not just antibiotics, and each of those independently have particular risks, and nowhere more obvious than with the COVID pandemic of this year. So it is good to see that WHO have moved across to recognise that. In recognition of the fact that we know that many of our community patients, there is a real knowledge gap of understanding. There's been lots of international research about knowledge and attitudes, particularly understanding what antimicrobial resistance is. And really what has become clear from all those studies is that the basic understanding of what an antimicrobial is still an issue, as well as the sort of infections that they are treating, and that the terminologies used by these different cultures don't often translate very well into the term. So this year it's been so much fun over the last few weeks to have many volunteers to translate our infographic, which is on our website, into lots of different languages, and we have more coming. I've just managed to garner a Norwegian translation and hopefully a Pidgin translation as well, so we'll be putting those on as they come online. You can't talk about AMS at the moment without considering the impact of the COVID pandemic, and it's absolutely clear, and we saw it in our own precinct, how disrupted our AMS programs were by the clinical service delivery changes. And really it has led to fundamental reorganisation of our hospitals and ICUs worked. In addition, in many sites around the world, there was disruption to antibiotic supply chains. And one of my concerns is that this, as alluded to by Paul, there's been this pivot towards emergency development of vaccines and antivirals to treat COVID-19, which is, of course, is entirely appropriate. But we also need to consider what a challenge antimicrobial development has been and will continue to be, particularly with the huge costs. And we'll be hearing from Mark Blaskovich and his team a little bit later. We also saw that there was high use of empiric use of antimicrobials, particularly early on in the pandemic, and wide use of agents such as azithromycin, and there was widespread concern about the unintended consequences of this in terms of antimicrobial resistance. This is probably going to be a contributor, but also the serious challenges with undertaking diagnostic tests for secondary infections when patients are in isolation will no doubt have impacted on the potential empiric use rather than directed therapies. And so what we saw was probably many challenges with following our fundamental AMS principles that we do in a non-pandemic setting. But there probably is a silver lining to all of this, because what became very clear, and for all those armchair epidemiologists around the world, and infectious diseases, our armchair infectious diseases physicians, we saw that really what the pandemic highlighted was that, well, there weren't the systems in place to deal with the pandemic at the very outset, and that was nowhere more evident than in some of the areas such as aged care. And so what we do need to move towards is an integrated system approach where there is real high quality data sharing, real time if possible, to monitor what is going on in our healthcare systems. And I'm now talking not just hospitals, I'm talking about aged care, primary care. And additionally, the availability of an adequately trained workforce, and again, highlighting the issues in aged care. I'm sure many of those online, the RD physicians and particularly pharmacists, which I know there are many watching, our AMS experts were essential to the response, mainly because their skill set in actually setting up systems. And I think we should remember that and harness that. What was also fantastic is that we saw new, quite effective models of care, virtual hospitals, the use of telehealth, and the urgent transformation in aged care, and the plan to bring in infection prevention practitioners into each aged care home. Obviously, AMS is going to need to be really, qualities of medicines more so, is being highlighted by the Royal Commission in Aged Care as an urgent requirement as well. And also it was really great to see people stepping up into positions of leadership, and we do not harness nurses who are the coordinators of patient care often, and pharmacists who can assist with this. So highlighting, we will have Crispin Hackwitz from Royal Brisbane and his team talking about some of these issues around AMS in COVID-19. The lessons learned, and also, as I mentioned, Mark Blaskovich talking about the accelerated development of antimicrobials in that session. In building the COVID-19 response efforts, again reflecting how AMS stewards can be harnessed in the current and future response efforts, I think if we think about the core stewardship activities that we already do in our own AMS programs, in particular prospective audit intervention feedback, formula restriction authorisation, streamlining and de-escalating therapy, delivering education, viral switch to allow earlier discharge, engagement with microbiology and infection prevention, the development of clinical guidelines and pathways. These are all core stewardship activities that were no doubt implemented in many hospitals with their COVID response. And in Australia, where we have quite advanced antimicrobial stewardship programs, this was core business. However, you can imagine in many hospitals without AMS programs, infectious diseases expertise, rural regional hospitals, these are the type of skill sets that would be essential to actually deliver a response. What we did see though, and what we hear a lot, is that all these activities to manage the outbreak was diverting the teams away from traditional activities. And at the moment, it's fair to say that while we have quite reasonably well-stocked AMS teams in principal referral hospitals, we do know that as we move away from metropolitan and principal referral hospitals, those resources start to diminish, and there are obviously other models of AMS that need to happen. And so building these skill sets in other healthcare workers, I think, is really important. So moving now to the National Antimicrobial Resistance Strategy, and again highlighting that this is now going to be a true One Health approach, which is fantastic. The antimicrobial stewardship and judicious use objective, I've highlighted the three there. So the first one is to ensure that we have coordinated evidence-based prescribing guidelines and best practice, which are developed and made easily available and encourage their use by prescribers. Again, this is something which requires implementation, and we often hear from our colleagues in other sectors, including primary care, where access to the therapeutic guidelines at the point of care is not always easy with the current systems. Aged care, they may not have appropriate implementable guidelines for routine care of their common infections. Number 2 is to develop and implement effective mechanisms to monitor, reward and enforce compliance. And I've highlighted those because clearly we have made some headway in terms of monitoring our quality of use, particularly with the NORSE program and also the NAPS program, where we can understand appropriateness of use. The reward and enforce compliance. The compliance, I guess, has been driven mainly by hospital accreditation, and we certainly have standards now in aged care and some standards that may be relevant in general practice. The reward, we don't know, and I know with our discussions with the department, there is no funding mechanism for antimicrobial stewardship programs, and the only country that I know of where there's actually a true reward program for AMS is in Japan. And so it would be interesting to think to support to cost and fund these programs, which do require resources and trained staff. And number three is really to use the data to inform policy and to develop these targeted, timely and effective responses. So this is where implementation comes into play, and we need to be thinking not just about surveillance now, but how can we close the gaps in quality of care to effectively implement in a timely and effective way, and also to be able to intervene in areas where there are clear gaps or AMR, antimicrobial resistance issues. Of course, it's pretty obvious to say that there's no one size fits all, and we do need to consider the challenges of each of these sectors, the regulatory environment in which it operates, and what are the actions that are already taken. And we can certainly say that some sectors are well ahead, and it's fair to say that Australia is an international leader in hospital antimicrobial stewardship, but we still have a way to go in the other areas. So I'm going to talk about this concept of a learning healthcare system, which is my new favourite thing at the moment, because I think it embodies the type of approach for something as a wicked a problem as antimicrobial resistance. And as an antimicrobial stewardship, my focus has always been fairly and squarely on antimicrobial usage as a patient safety issue and quality of care issue. And with that, if you're using antimicrobials appropriately, there will be intended consequences and obviously potential unintended consequences around antimicrobial resistance. But the primary focus for the prescriber at the point of care should be around patient safety. The learning healthcare system really is moving into a model of care which is obviously a socio-technological response, where we bring in science and informatics and culture to create a continuous improvement process, and you deliver these improvements into the delivery of care, and you capture the knowledge as you go, and then you feed that back and continue to improve care. Many of us know the knowledge translation cycle or the PDSA cycle, where we're creating data, improving. This is not new. But what is really important is that we need to recognise that there are social issues that we need to consider, the research and scientific drivers, the technological issues to do this properly, make sure that there's policy drivers that will align with our efforts. There are ethical and legal issues, and particularly in our world digital strategy moving forward, there are huge barriers still to free, to be able to share data across jurisdictions, across sectors. We've heard lots of issues along the way around how we're going to be able to do that to maintain patient privacy, to drive out improvement. And then ultimately the key outcome of this learning health system may be a value around what's the benefit to the population, the patient experience, the provider experience, and healthcare costs. So I've mocked up one which I think reflects what a learning health system is for antimicrobial stewardship. And ultimately, starting from the data, and here we need to be moving to methodologies that support passive surveillance to allow automated collection and assessment. But this would be collecting patient animal data from various prescribing systems and clinical encounters. And fundamentally important for antimicrobial stewardship is actually understanding the indications for use. It might sound simple, but it actually isn't. And we know from all our research in NCAS that understanding the indication of use for an antimicrobial, which is so fundamentally important, is often missing. Although we do know from the NAPs that this documentation is certainly improving. And there are many data sources that we have already, as well as administrating coding data, registries, and we have major challenges moving forward about, well, what are the data? If we're going to be linking this data or creating a national surveillance platform, we need to think about this data. How interoperable is it? And certainly with NCAS, one of the things that we have done is to develop our universal indications. This across the different sectors. What we haven't done so much of, which I think is really important, is to aggregate our data. So what is the relationship between usage and resistance? What's the relationship with usage volume and appropriateness? And does this process improve the targets for action that we need to address? We do have pretty good metrics, I guess, in hospital stewardship, but do we have established metrics that we can use for national surveillance and benchmarking in other sectors such as aged care, primary care and veterinary? And this is really important because a key requirement for our strategy is to understand appropriateness of use, and so therefore we do need to understand that. And you'll hear from Anna Kanina later in the week about our international Delphi study that established the metrics for appropriateness for antifungal stewardship. The next piece is using this data to inform practice change, really establishing AMS type programs that are sector specific and that are implementable, sustainable and effective in each area. These are obviously areas that we are working with, but clearly, because of 8 out of 10 antimicrobials are prescribed in the community, we must be focusing on primary care, aged care and companion animal use. We next need to think about how we would evaluate these outcomes. There's been virtually no, very little information around the cost effectiveness of the programs. It's a complex thing to study, many confounders and complexities in our healthcare system. But I think it's something that we do need to do, because we need to do that to be able to inform government if there's going to be some sort of models of reimbursement for these programs. And the last but critical piece is the establishment of effective communication and feedback. And this is a huge piece of work that needs to, again, be considered carefully in terms of the unintended and intended consequences to our prescribers. And many of you will be aware of the nudge letters sent by the Chief Medical Officer around antimicrobial use, which did improve volume of usage in high level prescribers. So moving on to technological solutions, which is an area that I'm particularly interested in, because as an antimicrobial steward and a physician implementing these programs, we know that at a day-to-day level of monitoring patients, prescribing is very time-consuming but important, and we have seen real impact on quality of prescribing through our antimicrobial stewardship teams. But at a broader level, how can we support surveillance that can be used to understand quality improvement, both at a hospital, jurisdictional, even national level? And it's challenging, and can we make it easier? So are we able to automate surveillance? What can we use in terms of AI, machine learning, natural language processing? And then thinking about, are our electronic health records fit for purpose? Many of them were designed as billing systems rather than systems that can capture patient details in an easily accessible way. And again, I reinforce the issue around indication documentation, which is a real challenge. So we are working in that space right now. And on Thursday, I'll be talking about the challenges and the pitfalls of using electronic medical record data. Joanne Mansky-Nankervis will talk about our work in establishing the GP NAPs, where we are actually using machine learning to undertake the appropriate assessment from data passively extracted out of GP programs. And Brian Herr is one of our PhD fellows with NCAS, who has also been using machine learning to do this in veterinary practices. It's really, really exciting. And finally, Jake Valentine, one of our PhDs from Peter Mac in CIC, will discuss the challenges of using administrative data, particularly ICD-10, the pitfalls of that, but also opportunities to look at enhanced surveillance using some clinical data, and that will be a great session. The other thing I'd like to mention, for those of you that are interested, University of Melbourne will be launching its Centre for Digital Transformation of Health on November. This centre will be certainly a major player in our precinct in terms of establishing these novel virtual models of care, data linkage, and other key initiatives that will be really important to build these learning healthcare systems. Moving on to the NAP, something which really is a marker of great success in translation, something which came out from NHMRC partnership grant and then NCAS. It has been continually improving and growing since it was first done as a I think it was a Survey Monkey back in 2011, I think it was. So Kaz Chen will be talking about and leading a session on how NAPS has been, what has happened over the past decade, how we have scaled and translated the program, both in sectors and also with our international colleagues. And we'll hear from our team from Canada, Miranda So and Yoshi, who have implemented NAPS in over 30 hospitals in Canada, and they continue to expand the program, and they've been great collaborators, as well as Sheila from Malaysia. And then Rod will talk about the role of the NAPS as we move forward with that international scaling. The NAPS at the moment is obviously a key element to the ORA surveillance program and supports hospital accreditation. It is a rich data source, and I encourage for those of you online who are interested in doing a project with us, we've been able to publish some really important pieces that have driven programs. So Jason Triviano, who identified that 18% of hospital patients had an antimicrobial allergy label. Brendan McMullen, who published this year the pediatric prescribing. Courtney, who has published some really major papers that have achieved international attention on surgical prophylaxis. And we have some more papers in process at the moment. Abby Douglas, one of my PhDs, looking at antimicrobial use in cancer patients, and Anna, who is looking to publish the antifungal use. So this is a graphic of NAPS over the years and where it was positioned as a various AMS national policy activities happened, and how we adapted the NAPS to meet the requirements of our users. And this again is this learning healthcare system response, that PDSA cycle that we continually improved it. Did surveys with our users, enhance the functionality. More recently, the Excel uploaders significantly reduced the time to do NAPS, and of course, we'd love to move towards a more automated model and to standardise and make sure that our assessors are able to undertake appropriate assessments. The e-learning has been really important, and we're very excited to continue to work with the Department of Health team as we continue to build the NAPS. So if we look at the at the metrics, some key metrics from the NAPs and what's happened over the last 5 years, you can see that the lighter blue line, which is the prevalence, is sort of trundling along without major changes, although you need to remember that different sites, different size hospitals come in and out of the NAPs over time. So this is a very crude measure. We can see a significant increase in documentation, which is fantastic, and probably some of that is actually driven by electronic healthcare records where indication is often mandatory. And we can see that there's increased in documentation of review and stop dates, which is also fundamentally important. What we have seen is some minor improvement in surgical prophylaxis, but at the end of the day, we are still seeing appropriateness. There is a gap there. It's a little more alarming if you break it down by the actual hospital types. And here I'm presenting the data in terms of the Australian Institute of Health and Welfare hospital classifications. And here you can see that principal referral centres are really doing really very well. And that's obvious, is that the principal referral centres are exactly those sites where they have established ID departments and funded stewardship programs. Look at the other public hospitals, and these are the very small, more regional, rural hospitals where they will struggle to actually demonstrate continuous improvement without the appropriate resources. I've also highlighted the performance in women's and children's hospitals, and we see this also in the cancer space with data from highly specialised units where a lot of the care is actually highly protocolised, and there's very close involvement of consultants in patient care. And here you can see quite remarkable, very high rates of appropriateness from the NAP surveys. And here I've highlighted the privates where is this gap. If we think about surgical prophylaxis, a particular area, because I'll talk about this a little bit more as we move forward, this is another area. We developed the SNAPs because surgical prophylaxis was one of the most common indications in NAPs, but also was continually showing very high rates of inappropriateness. And Courtney, as part of her PhD, analysed all the SNAPs data to look at appropriateness across all surgical groups. And you can see wide range of inappropriateness for both procedural and post-procedural antimicrobial use. And the most common reasons were incorrect timing for the procedural and post-procedural for extended duration, more than 24 hours. And just this week, we've released the Surgical Prophylaxis in Australian Hospital Survey, the SNAP survey results, which are publicly available. And again, those results reflect the data from previous years. So without putting interventions in place to close these gaps, it's not altogether surprising that we'll continue to see that almost 50% inappropriateness. So we have a session next Monday, which I encourage you, particularly those of you working in that space, where we'll have Kristen Zenos from Australian Commission, Rod and Sin and Courtney talking about the surgical NAPs in detail, Trish Peel from the Alfred, who's also an NCAS CI, looking at clinical trials, addressing guideline uptake, and then the New South Wales Clinical Excellence Commission, Sim Galliman, who will be talking about some tailored tools, so that will be a great session. I could talk for a long time on antimicrobial prescribing in the community, but we need to remember the majority of antimicrobials are prescribed in the community. And here we're talking about primary care, community vets, aged care, both aged care homes as well as in-home care, dentists. I love this icon, it's so cool. Indigenous health and community pharmacists. And so there's a lot to talk about. But there are many barriers to how we can implement stewardship in these areas and to sustain continuous improvement. If we think again about our learning healthcare system, I think we do have lack of clinical pathways and AMS in approaches to some of the common infections. And We're not talking about sepsis this week at all, but it really is one of the fear of serious infections, obviously one of the drivers for prescribing in the community, and we actually lack a national program addressing this. Again, reflecting back, we do have workforce capacity issues, and finally the community engagement, social awareness. So we have a series of sessions this week and next week which will address some of these areas. Teresa Wozniak will chair the session of AMR and Regional and Remote Australia. She has done incredible work with the hotspot surveillance program. Again, thinking about the social determinants of health is really critically important. Nolan Bennett will chair the AMS in the community, looking at what needs to be done in aged care and reflecting on the findings of the Aged Care Royal Commission and how that might drive AMS. Primary care, patient consumer co-design is fundamentally important, that we co-design and involve our patients in how we implement these programs. And then Sahel will be talking about the role of community pharmacists moving forward, which is not really something which is huge in Australia, but certainly something the UK is a little bit ahead in. On Friday, Leon Worth will chair a great session on the immunocompromised patient population, which has its own individual challenges. Brendan will chair the paediatric AMS and some great sessions. And then finally, a really great session chaired by Rhonda around AMS capacity building, and this includes the role of pharmacy technicians, dentistry, women's hospital. So how do we close the gap? Well, really, we need to consider how we implement our programs, and this is where implementation science research becomes so important. It's probably the missing piece in what we've done. We know that most studies show that clinical guidelines are not followed 50% of the time. So the fact that we're actually at 75% appropriateness in antimicrobial use is actually pretty good. But also there's a lot of contraindicated care. And so that concept of de-escalation of antimicrobials is something which is included here as that concept. And antimicrobial prescribing is a very complex system involving the patient, teams and groups, the hospital and the systems, and we need to consider all those factors when we're establishing these programs. So implementation generally needs to involve a behavioural approach, and that's why you hear these words, these frameworks. And if we consider a very basic question, is the guidance or is the policy actionable? And on the right-hand side, you can see an image of a particular framework, which is called the ACT framework, where we consider what the action is, who the actor is, what the context, target and time. This is an ACT framework around implementation of hand hygiene programs. What has been clear when we look at the evidence around effective AMS programs, many of the studies talk about what needs to be done where and to whom, but very few studies talk about who needs to do it and when they should act. And this is something which we can easily go back to in our own hospitals to think about our own policies and guidelines. Are our guidelines written in a very passive scientific approach, or does it actually tell you who needs to do what and when they need to do it? And this is something which can be done immediately now. I won't spend a huge amount of time other than talking about this behaviour change wheel, which is a compilation of other frameworks which identify how you would implement something based on the findings of the qualitative assessment. And really it is a way that you understand the behaviour and really provide some structure into how you analyse your programs to identify barriers and enablers and help to drive implementation, development and evaluation. This is a really important framework which we have used in our own research, and we're very fortunate to have Jill Francis, who is an implementation science, who's just come back from the UK, who's involved in the development of these frameworks, and NCAS will be working very closely with her as we move into our implementation phase for our programs. And if you're interested in hearing Jill talk about these frameworks, we have a an hour-long webinar on the website, and I strongly recommend that you watch that. It's a fantastic introduction to implementation science in antimicrobial prescribing. So Courtney, one of our fellows, she's finished now, did a really great study looking at qualitative focus interviews with around surgical decision making, but with surgeons from different craft groups, anaesthetists, pharmacists and nurses. And here you can see some of the challenges. You know, you can write all the guidelines that you want, but if the boss wants to do something else, you're challenging them. Or where you feed that audit data back, doctors are very competitive. People don't like to be down at the bottom of the pack. And it was clear from the barriers and facilitators in surgeons at least that perhaps having benchmarking was something that they would possibly be happy to have, but also that they needed to retain their autonomy. And so Courtney has proposed a framework using the elements of the behaviour change wheel, establishing collaboration engagement with the key specialty colleges, the commission, the therapeutic guidelines, to make sure that the surgical prophylaxis guidelines are actually implementable, and partnering with the other key stakeholders in the surgical prophylaxis pathway to build on the surgical NAPs to make sure that we can focus on the real targets for stewardship, and then to develop the various interventions that might improve surgical prescribing. And in my last couple of slides, really, we need to, this is the other priority area for action, is where we need to develop an and really establish that whole society awareness and behavioural change. We often hear about Mark Davis talking about antimicrobial resistance as a zombie issue, because you see little bursts of papers around CRE or MRSA, and you get a little burst, a patient story, and off we go. And then a few months later, we see another one, but nothing ever really changes. How can we actually really create true awareness? And this will require education and training initiatives across all the sectors. So November 24th, Mark will be leading a fantastic session around qualitative research here, particularly highlighting some of these issues around drivers for prescribing. I think we need to really consider the cultural and linguistic diverse communities in Australia and some of the fear issues that drive prescribing. I'm very excited to be kicking off a discovery grant with Mark and University of Glasgow and Copenhagen, where we are actually going to be deep diving into a consumer-focused analysis of what we need to do in terms of developing this communication strategy and how we can co-research with our providers and our consumers. So lastly, my very last slide is really that this is a global effort and we need to work together across all our sectors in Australia, but internationally. And the final session I did want to highlight, which will be chaired on Thursday, is really what we're doing in terms of building our regional capacity. And this is a really exciting program of works. We have both Fleming Fund, DFAT and WHO initiatives that we're working with, and Ben Howden will be concluding that session, so that will be fantastic. So I'll finish on that and thank everyone for attending today, and look forward to hearing your comments and answering questions over the week. Okay, so next on, we now have Glenn Browning, Professor Glenn Browning. So I've had the great pleasure working with Glenn over the past 5 or so years as the animal stream lead for NCAS. He's a veterinary microbiologist. He has applied an understanding of the fundamental pathogenesis and epidemiology of ID to develop solutions to problems in animal health. He is a Redmond Barry Distinguished President Professor and Director of the Asia Pacific Centre for Animal Health, which is a multidisciplinary research centre within the university committed to improving animal health, welfare and production. And I welcome you, Glenn.
Thanks very much, Kaz. Let me just share my screen. And we should be away, hopefully. Okay, I'm hoping everybody can see and hear me. Please scream if you can. So the title that I gave Arjun for the talk today is Antimicrobial Use in Animal Health in Australia. What do we know and what do we still need to find out? And really, I'm going to sneak in a few other things about how we use data on antimicrobial use, and some of the information I'll include will refer back to things that Mark Schipp said or mentioned earlier, and also you'll see some parallels with some of the material in Kaz's earlier talk. And I've just included the, hold on, let me put that on a pointer. Will it let me? Yes, I've just included down the bottom here the banner for the OIE World Antimicrobial Awareness Week, to remind people of that. So I think Mark sort of covered this earlier, but I think it's always important to remind people that we use antimicrobials in domestic animals for a good reason. We use them to enhance health, welfare and production, but particularly with a focus on health and welfare. That's probably most commonly to treat diagnosed bacterial disease. We also use antimicrobials in a targeted way to prevent predictable disease. So particularly in animal production systems, there are diseases that we know will occur at particular stages of the production cycle, for example, in pigs. And so antimicrobials are used to control that disease that we know is going to occur in each age group of animals that pass through that part of the production process. They are also used, as they are in human medicine, to attempt to treat undiagnosed disease in a very empirical way. And that's probably one of the areas where we particularly need to focus some of our efforts. And they are used to improve production. Now, in Australia, we no longer use antimicrobials purely to improve production, but this is often a byproduct of treating disease, which is having an effect on animal health. So there are a number of challenges in trying to assess and monitor antimicrobial use in animal health. For a start, usage and patterns of usage differ considerably between the different animal species that we deal with in animal health. They differ between the different production systems, even within a single animal species. They can differ between different veterinarians and their approach to disease control, and they can be influenced by the owners of the animals, whether they are farmers or owners of companion animals. It's also important to remember we have a differing range of bacterial pathogens in the different animal species, and quite different patterns of disease associated with those different bacterial pathogens. So some of the differences in antimicrobial usage will be influenced by those different pathogens. We also treat animal disease in quite different ways. So animal treatment for companion animals is very, very much targeted at the individual animal, and has a lot of parallels with human medicine. But we use group treatment for most of the food animals because they're in large aggregations. There are too many of them in one place to be able to go around individually dosing each of those animals on a regular basis. The other particular challenge that we face in veterinary medicine is that most veterinary practices and most farms are small businesses, and so they don't have the resources to institute large auditing systems that are dedicated to collecting data on antimicrobial use. And so some of the methodology that's been used to collect data I don't know why my slide has progressed there. Some of the methodology that has been used to collect data through audit in large tertiary hospitals is not going to be applicable to veterinary practice in general. At present, the only data, or up until recently, that we've had available from government agencies and through legislative systems has been the total amounts of antimicrobial imported for veterinary use. And in a moment, I'll tell you why that data is not necessarily the most reliable data to use to really understand how antimicrobials are used in animal health. And the other problem we have is that because of the way that antimicrobial susceptibility testing is conducted in animal health, most of the susceptibility data we have on the major bacterial pathogens is pretty much historical data, and some of it's very close to ancient history. And so we don't really have good contemporary data in a lot of settings to guide the use of antimicrobials to treat disease. So it's worthwhile considering when we start talking about antimicrobial use in domestic animals, just how many animals there are in Australia. So in the table on this slide, you can see the numbers of the different species and different production types that we have. So we have around about the same number of beef cattle as people in Australia. Dairy cattle is a much smaller cohort of animals. We have something like nearly 3 times as many sheep in the country as we do people. We have 3 million pigs. We have something like 100 million chickens between both the meat and layer chicken sector. And then dogs and cats are a smaller proportion. But I guess the one thing to remember here is that dogs and cats are living with us all the time and so have a very close association with humans. And so often there can be significant sharing of organisms between dogs and cats and therefore potentially resistance. This is the data that we have on antimicrobial imports. The last published set of data was in 2010, and I've divided this up into the different classes here, and the colours on each bar indicate what those antimicrobials were apparently imported for use in, what species they were apparently imported for use in. So you'll see that there were probably most significant amounts of antimicrobials imported for use in pigs and in poultry. And one of the problems with these data is that we know that particularly the importation of penicillins, most of those penicillins that were imported for animal use for poultry was amoxicillin, and most of that was almost certainly used in the pig sector rather than in the poultry sector. So the importation data can be misleading about where those antimicrobials eventually end up being used. The other set of data that's available are the declared sales of antimicrobials for animals. So these are the dollar value of different antimicrobial groups that are reported by the companies importing those antimicrobials. And these are the data stretching across the last nearly 15 years. You can see that the categories aren't particularly useful here, so we have them divided into oral, parenteral, intramammary, sulfonamides and other anti-infectives. With the exception of the sulfonamides and to some extent the intramammaries, we don't really know what class of antimicrobial we're dealing with here. And we don't really have any good understanding of why that appears to have increased in 2018, 2019. It may have just been an increase in price. It may have been increased use. So all in all, these data aren't particularly informative, particularly if we're trying to use them to interrogate whether antimicrobial use is appropriate or not. So I think this slide really just summarises this. The data can be misleading about the species. The antimicrobials may be used for indications other than those on the label, and where there are multiple species listed as being treated with that antimicrobial, the companies provide an estimate of the proportion of the product that's used for each species, but that may not necessarily be an accurate reflection of what the product's really being used for. We don't have any way of assessing appropriateness of use, and we can't determine why there might be changes in use because we don't really know where it's going. We only know that it's coming into the country. And it's really of no use in trying to assess variations between individual veterinarians and individual farmers, and doesn't really enable any within-country benchmarking. It enables some benchmarking of our performance compared to other countries. So when we initially started working on these problems about 6 years ago, we started out with a range of different approaches that would gather data that would tell us somewhat how antimicrobials were being used out there in the animal health community. So we surveyed veterinarians to determine what their attitudes were to antimicrobial use and what decisions influenced their prescribing. We developed and have trialled a mobile survey tool to enable collection of data on prescribing in veterinary practices, the aim being to deploy this into the hands of veterinary students who are out there working in practices. You could almost say as a free labour source or a renewable free labour source. We've been, in the last couple of years, starting to trial rapid audit methods for veterinary practices, and particularly one of our research students, Susanna Richards, is developing that method. So something that might be applicable in a small business that doesn't take much time, that could generate some data about antimicrobial prescribing and feed that back to the practice that's using the audit system. We've been particularly focusing on trying to use what you might call found data. So data that's collected for another purpose, but is analysable and will provide some information about antimicrobial use and prescribing. So we've particularly, with the help of some significant partner organisations, been able to analyse pet insurance data and also practice management system data to be able to get a good idea of what antimicrobials are being used, particularly in companion animal practice. And this is quite a rich data source and can give quite a lot of information about what's being used, when it's being used, and particularly with the practice management systems, Brian Herr is now being able to extract some information about why it's being used as well. Ultimately, what we've been aiming to do is to provide data so that veterinary practices and practitioners can then compare their use to that of their colleagues and get some idea of whether they are on track with their colleagues or whether they're out of step. And the other reason for collecting this sort of data is, as Kaz has mentioned, to use the data analysis to compare the effects of stewardship interventions. And towards the end of this talk, I'll mention some of those. So initially we surveyed veterinarians across Australia. We got good responses to the surveys. Probably around about 10% of the profession responded to the surveys. And it was a good representative sample of the profession. And what we explored with them was what they would use, particularly in surgical situations. And I guess our focus was on surgical prophylaxis because we felt that that's probably the area where there was most ground to be made on antimicrobial use in veterinary practice with fairly easy gains without much controversy. And you can see here where veterinary practitioners would never use antimicrobials, so that's in blue, sometimes or rarely use antimicrobials, or always or frequently use antimicrobials. And I think one of the things that really pops out here, we picked a number of different situations where antimicrobials might commonly be used, ranging from routine clean surgery through to trauma surgery. And you can see there are quite significant differences between dog and cat practice and equine and bovine practice. Now, some of that is explained by the concerns of veterinarians who are performing surgery, particularly in the case of bovine practice, performing surgery out in the field where they don't have a sterile, well-regulated environment to perform the surgery. But there is probably more use of prophylactic antibiotics in both equine and bovine medicine than is necessary, and probably more used in companion animal practice than is necessary as well. We have also assess the compliance of this use with guidelines that we had established, and you can see that while in some situations the compliance was reasonable, in other situations the compliance was predominantly suboptimal. I guess of particular concern to me is the fact that routine surgery in small animals like spays and castrations, very common surgeries performed in veterinary practice, that are performed as elective surgery in a very clean environment are still being treated prophylactically with a lot of antibiotics when it's really quite arguable that antimicrobial use is warranted at all in this situation. Again, you can see the difference here between the compliance with guidelines in companion animals compared to equine practice. Now, I think what this highlighted when we looked at these data was that there was plenty of area here to promulgate antimicrobial use guidelines much more widely in the profession, and we set about doing that immediately after we received the results from this survey. The other factor that became apparent was that there was a significant gap with some antibiotics between the optimal dose that was recommended in the literature and the label dose on the product, and that was in some cases driving underdosing with antimicrobials in particular situations. So this is happening particularly in both cattle and horses. The data I've got on the slide here are the data for cattle, where you can see that the dose for penicillin that is recommended in the literature is at 22,000 international units per kilogram, but the label recommends half this dose, and the majority of veterinarians were underdosing cattle with procaine penicillin. And similarly with oxytetracycline, where the label contains a range for the dose between 4 and 10 mg per kilogram, there were a significant number of veterinarians who were dosing at the low end of this range, when the literature would suggest that the appropriate dose rate is at the top end of that range. So some veterinarians, getting up towards 40% of veterinarians, were dosing at the literature recommended dose, but a number were being led by the label. And one of the consequences of this has been for a change in at least some products in the label. This is still a bit challenging through the legislative process, but at least some companies have started to change the recommended dose rates on their labels, particularly for gentamicin in horses. The other approach we took was to use what I call the found data. So with collaborators at PetSure Insurance, who provided us access to their claims data for something like 1 million claims over a period of 4 years, we were able to explore the antimicrobials that were used across both dog and cat practice in Australia over those 4 years. And you can see the results of that analysis here. It's expressed in the number of prescriptions per 10 dog years or per 10 cat years. And you can see the total number of prescriptions across the top here. You can see in dogs, it has a distinctly seasonal pattern, which we'd expect because skin problems in dogs tend to peak during summer, and we're seeing that in the pattern of use. You don't see anywhere near as much seasonality in cats. You can see that there is less use in cats than there is in dogs. And you can see the predominant antimicrobials that are being used. So the most commonly used antimicrobial was amoxicillin clavulanic acid, followed by cefalexin, and then metronidazole. In cats, the predominant antimicrobial used was amoxicillin clavulanic acid, although that was very similar to the use of cefavecin, which is a third generation cephalosporin. And I'll come back to that in a later slide. So we were able to use that data to work out the annual exposure of the dog and cat population in Australia to antimicrobials. So around about 19% of dogs and around about 10% of cats are exposed to antimicrobials in any 1 year in Australia. And we were able to compare that with equivalent data available for humans. And you can see that we are treating our dogs with antibiotics about twice as often as we're treating our adult selves, but much less than we're treating our children. and cats are being treated about half as many times or half as often as dogs. Now, while it's certain that there's potential for improvement here, it does suggest that we don't have as much antimicrobial treatment of our pets as we do of our human population in Australia. And this was really the first time that we've been able to get a good handle on just how much antimicrobial prescribing occurs in companion animal practice in Australia. Now, parallel to this, Brian Herr, who Kaz mentioned before, has been working on data mining clinical records across a large number of practices, and he's been able to use natural language processing to pull information out of those clinical records. So this is not data that's entered in with any intent of it being retrieved in this way, but Brian is able to extract out each time an antimicrobial is mentioned in those records, and he's starting to work on being able to determine what sort of indication these antimicrobials are being used for. One of the things that's apparent from his data, and you can see here on the left, is that there's very considerable variation between different clinics across the practice network that's involved in their usage of antimicrobials. Some practices are using antimicrobials at something like 5 times the rate of others. Now, this may reflect differences in the type of practice, but it's certainly a variation that's worth exploring further. The other thing that he was able to do was look at how much use of ASTAG high importance antimicrobials were used per consult. And you can see through the color here, because this is color coded, you can see that some clinics are using a much higher proportion of ASTAG highly rated antimicrobials than others. Again, something that's worth exploring. Now, one of the pleasing things out of this analysis of Brian's was that it concorded fairly closely with the insurance data. Now, there was an argument when we started doing the analysis of insurance data that may be misleading because the insured population of pets could be distinctly different from the remainder of the population out there. I think I would argue that they are probably the population that's more likely to be treated than the rest of the dog and cat population, but we couldn't be certain about that. Now, the use of antimicrobials that came out of Brian's analysis suggested quite a lot of concordance between the two quite different sets of data, in that amoxicillin clavulanate still came out by far and away as the most commonly used antimicrobial, followed by cefalexin and then cefavecin. So this is not separated by dogs and cats. But the analysis really suggests that what we were seeing in the insurance data was supported by this data mining approach. The other pleasing aspect of this analysis was that when we looked at some of the most highly ranked antimicrobials, and we had a fear that there may be some use of these antimicrobials, Brian was unable to detect any use of the glycopeptides like vancomycin and teicoplanin, any of the 4th generation cephalosporins, any of the anti-MRSA cephalosporins, the carbapenems, or the streptogramins and monobactams. And I think that gives us some confidence that companion animal veterinarians are not employing antimicrobials that we would be particularly concerned about as being of very high importance. The other way that this analysis was able to be used, and Laura Hardifelt and Brian Herr both together performed a cross-sectional study of cefavecin prescribing of all the antimicrobials in frequent use in companion animal practice in Australia. Cefavecin is probably the antimicrobial we have most concern about. It's a 3rd generation cephalosporin. It's very, very attractive to veterinarians, particularly in cat practice, because it has a very long half-life. It has a half-life of about 2 weeks. So a single injection of a cat at the veterinary practice is essentially the course of antibiotics. Now, the concerns are that we are using 2 weeks of treatment with an antimicrobial when maybe only 3 to 5 days might be necessary. and also that we may well be using this when a much lower importance antimicrobial would be suitable. The driving factor here is the difficulty that animal owners have in administering tablets to cats when they're sent home with antimicrobials. So over a 6-month period, Brian and Laura pulled out consultations in the practice management systems that mentioned prescribing cefovecin and analysed the indications behind that use of cefovecin. And you can see this here. The cats are in black, the dogs are in white. So you can see cats by far and away dominate the use of cefovecin in veterinary practice. And you can see that the indications along here are generally for things that are where the drug is going to be used for empirical therapy rather than in a diagnostic after a diagnosis has been made, a microbiological diagnosis. For dogs, the most common reasons for use were surgical prophylaxis. There's not really a particularly good argument for using a 3rd generation cephalosporin in veterinary practice for surgical prophylaxis. For cats, the most common reasons are essentially traumatic injuries and dermatitis. Again, a 3rd generation cephalosporin is not a really a justifiable choice in that sort of a setting. The number of settings where antimicrobial susceptibility testing was performed, which the label for this product would suggest is necessary, were exceedingly small, well under 1% of cases were subjected to any microbiological diagnosis and susceptibility testing. So I think this is highlighted that we have a drug here that is on the market. It's being quite heavily used, particularly in cat practice, and we probably need to, or we definitely need to, introduce stronger controls on its use. The other aspect of collecting this sort of data is to start implementing antimicrobial stewardship programs. And so about 2 years ago, we started implementing an antimicrobial stewardship program with the help and very strong support of Rachel Che, who at the time was with Green Cross Vets. Green Cross is the largest corporate veterinary practice group in Australia. They have around about 150 practices across the country. And the approach was to institute a 12-month trial with 3 different levels of intervention in antimicrobial stewardship, either education alone, education and some active interventions, or education, some active interventions and drug restrictions. And that program's now been in place for around about a year in these practices. The practices were allocated essentially randomly to one of these 3 different levels. And we are now starting to gather data on the effects of these 3 different programs on both the attitudes of veterinarians working in those practices to antimicrobial prescribing and the amounts of prescribing that has occurred in those practices since the introduction of the program. And the initial indications, very early days, are that the different programs are having an effect. The other aspect that has come out of our work on antimicrobial use in domestic animals in Australia was the very clear evidence that the veterinarians wanted more guidance, both education and guidance. And so they needed resources to guide their use of antimicrobials. So we created a number of antimicrobial use guidelines, Laura Hardyfelt in particular did, and these have been available as open access on our website. They are there for companion animals, for horses, for cattle. We also have guidelines there for antimicrobial stewardship programs if veterinary practices wish to institute them. And we have a number of resources that we've developed, particularly in association with Agriculture Victoria for veterinarians. Our online guidelines, the last check earlier this week, have had 27,000 or a bit over 27,000 page views in the last 12 months. So I think this is a good indication that these guidelines are being well used by veterinary practitioners out there in the community. The other resources which Mark Schipp mentioned that we've developed with Agriculture Victoria, he mentioned the ASTAG ratings. So we've developed with Ag Victoria these rapid check cards, reminder cards about the different importance ratings of antimicrobials across all the major domestic species. You can see a sample of those here. And so these are used, they've been distributed out to veterinary practices. They've got a magnet on the back so they can be stuck on the drug fridge and may help guide some use of antimicrobials. We've produced poster forms of our antimicrobial prescribing guidelines. These are able to be adapted by the practice, so they can develop their own policy and put those in on the poster. And these are available for both dogs, cats and horses. And we've supplied those out with the support of the AVA and Agriculture Victoria. And Laura and Kirsten Bailey have particularly developed a pocket guide for horses and for dogs and cats, again, in collaboration with Agriculture Victoria. And these are very quick reference guides that can be stuck in the pocket of a veterinarian to guide them about which antimicrobial might be most suitable for the different organisms based on the best available data that we had on susceptibility of those organisms in Australia. So I promised at the start that I was going to talk about what we need to know. So just to finish up the things that I think we still need to know, we need to know whether we can extend at least aspects of the Green Cross stewardship trial into other practices. We've instituted this and implemented it in a large corporate practice group. The question remains whether we can introduce that into individual practices where the workforce may be smaller. We need to know how we can further refine and focus those companion animal stewardship guidelines. We've got a large number of elements in the current program with Green Cross. Some of those elements may be working and some may not. And we are going to go through surveying the veterinarians who've been part of that program to find out which parts they found too onerous, which parts worked most effectively. We've now got a lot of data about what antimicrobial use looks like in companion animals, or at least in dogs and cats. We do need to know more about what antimicrobial use looks like in horses and in our food animal populations, including down to the indication level that we now have with companion animals. We need to think through and work out the best ways to assess appropriateness of use in food animals. This will be a combination of both dose rates and durations of use, but having a measure of what dose rates look like in the different animal species is going to be important to compare levels of appropriateness between species. That said, the most important use of this data is actually to guide use within any individual species rather than to create ranking tables between different animal species and different farming types. One of the areas that one of our research students, Steve Little, is working on is how we can enhance the use of in-water medication in intensively raised livestock. Medications to intensively raised livestock are typically administered either in feed or in water. Administration in water is a much more adaptive way of medicating intensively raised livestock, but there are some challenges in some systems, particularly in the pig industry, in doing this effectively. And Steve is working through how we can do this more effectively in the future. We need to think through how we're going to benchmark use between veterinarians and between different farms. We need to think through very carefully how we can deliver antimicrobial stewardship in production animal settings, because it is much more complicated in a production animal setting than it is in a veterinary practice setting. There are more players involved. And we need to find out a way to get, to aggregate and obtain more contemporary data on antimicrobial susceptibility of many of the major pathogens of livestock to insist in our guideline design. At the moment, we have best guess guidelines, but we do need more data to support those guidelines. So really, to conclude, I won't go through the full list of everybody who's contributed to this. On the right there, you'll see there's a large number of people who've contributed to our work over the last 5 years. These are both staff members at the Veterinary School and the University of Melbourne. They are research students who have put in a lot of work into this output. And they are our collaborators, both in other parts of the university, for instance, in computer science in the university, CAS, of course, and our medical colleagues within NCAS, Claire Deeth from Agriculture Victoria, Josh Selinger and Mags Awad, who at the time was with Petshaw, but is now with Green Cross, and Rachel Che, who is now with APVMA, but was at the time with Green Cross Vets and helped, was essential to setting up the stewardship trial that I've talked about. And you can see our various supporters here, particularly the Fleming Fund, Green Cross Vets, Petshaw, NH and MRC, and Agriculture Victoria. Thank you.
Thank you, Glenn. That's a fantastic overview. Moving on, and I apologise, Ben, who's going to be talking. Ben Howden probably doesn't need a huge amount of introduction, really. So Ben is the director of the Microbiological Diagnostic Unit, Public Health Laboratory based at the Doherty. He's a medical microbiologist, an RD physician, and a molecular biologist. Ben really is responsible for the provision of public health laboratory services and the translation of microbial genomics into public health and clinical microbiology, and research investigating AMR and bacterial pathogenesis, evolution and host pathogen interactions. Welcome, Ben, and sorry.
Thanks very much, Kaz. Hopefully you can hear me and hopefully the slides are up. Yeah, thanks. Yeah, thanks very much for the invitation to talk. So my topic is more on the use of genomics and how we might be thinking about using pathogen genomics to enhance AMR surveillance. So, brief overview will be some background. Thinking about the models for implementation, how do we bring this to the clinical and public health interface? Some case studies and demonstrating progress to date. A bit about lab accreditation, because I think if we want to use this tool in clinical microbiology or public health surveillance, we need to think about how we go about laboratory accreditation. A couple of slides on international perspective and then a view to the future. So I'll scoot through some of the slides quickly and then focus on some of the key ones towards the end in a bit more detail. I guess just to bring people up to speed with where we're at, genomics of bacterial pathogens is really going to revolutionize microbiology. It's already doing that in the public health microbiology space, but will also move more into clinical microbiology over coming years. And what it does, it's a single technology really that replaces a lot of older techniques that we use in the laboratories and also gives us a lot more detail and information to play with. And here's an example of what that information looks like. So actually it's not that exciting when you see the raw data that comes out of the genome sequencing machine. But when you interpret that data appropriately, you can start to really get some really important insights into what's going on with pathogens. And this is just a diagram showing some of the key things that we can learn from microbial genomics, particularly around AMR, but also things around hospital infection control, detecting pathogens, improved surveillance and outbreak detection, and the source attribution. And many of these things can be applied in the AMR space. And then if you think about it in a bit more detail, exactly the main things that we do when we're talking about genomics and AMR, it's to really compare the genomes of different samples to each other. And so this is a slide from Torsten Seaman just with his chocolate tree. It's a phylogenetic tree showing that things that are closely related genotypically sit together on the tree. And it's one of the key tools and one of the key outcomes of genomic data is the comparison across different genomes. And then the other thing we can do is start to look for the presence of resistance mechanisms within this raw genomic data. And that could be mutations that are present, it could be genes that are present, and it can also be mobile elements that carry these resistance genes. And so all of this information can be gleaned from this raw sequence data file with appropriate bioinformatic processing. The other thing to highlight at the start, this is a very nice paper that's recently come out from our Queensland colleagues, is that there are a few different types of sequencing technologies we can use, and the most common is the short read sequence data, often done with Illumina, and that's mainly for detecting SNPs or single nucleotide polymorphisms and allowing us to form those phylogenetic trees to compare samples to each other. We can do other things with the short read data, but the other technology that's been increasingly used is machines that produce long reads, and these are very good for resolving plasmids and mobile genetic elements. And so a combination of the two really does give us a lot more information about the genetic structure and where things such as resistant elements or plasmids might sit. And then another thing that we can do is actually start to sequence directly from samples. And in this paper, there was a nice example of sequencing from a drain and demonstrating the presence of a resistant element and a bacterial species in the drain that was also found in patients. And this is called metagenomics. It can be done from drains, it can be done from samples from humans and the environment. And it allows us to link back some of the genetic elements that we might find in these environments back to what we find in patients. So why are we particularly interested about using genomics in outbreak detection and prevention? So this is an epidemic curve of an outbreak that could be anything really, a foodborne disease or an AMR pathogen. And using existing approaches, we might recognise the outbreak around this stage and start to put interventions in place around here, but what you then end up with is a reasonable size outbreak before it's under control. But the idea of using genomic technologies is that, for example, if all isolates are sequenced, you'll very early in the outbreak get this signal of having highly related isolates in more than one case, and you're more likely to be investigating and implementing changes earlier in the process and hopefully avoiding this large outbreak. And so that's the concept of how enhanced genomic surveillance will work across a range of pathogens, whether that's in public health, foodborne disease, but also for antimicrobial resistance. And so when I think about AMR and genomics, it's really quite a broad spectrum of potential applications. So we can use genomics in an individual patient. We can look at an outbreak in a ward. We can think about a hospital outbreak of an AMR pathogen. And then we can start to look at it at larger scales across institutes, whether it be in the state, country, or around the world. And all of, the technology has been used in all of these different settings. And where does this sort of sit in terms of the governance and the development and the research and the deployment? These three really sit either in a genomics enhanced diagnostic laboratory, or possibly through the use of a reference laboratory. And then once you move in towards state, national and international approaches, then it's a bit more at the public health AMR system or network level. What types of pathogens are we talking about in these different environments? Traditional hospital pathogens we're all aware of, CPE, ESBLs, VRE, MRSA. They're probably the most likely to focus in this environment, where when you're talking through public health systems, while these may be included if you're looking at community transmission of these key pathogens, which does occur, you're also focused on many of the notifiable diseases such as foodborne pathogens, Salmonella, Shigella, STIs such as drug-resistant gonorrhea, TB, drug-resistant pneumococcus, invasive bacterial diseases. And so the spectrum of pathogens we're looking at, and also the approaches and the mindset around them is a bit different. And then I guess the key part of using pathogen genomics is linking to epidemiological data. So metadata is absolutely key in drawing conclusions. In this environment, it's likely to be infection control practitioners or hospital epidemiologists, whereas over here, it's more of a communicable diseases epidemiology mindset where you're looking at the community and across different institutes and systems. So just a couple of examples now of how this technology is being deployed. This is an example from Victoria where many of you may have heard some of this data before, but where we had quite a large outbreak of KPC, so a very high risk KPC, Klebsiella pneumoniae outbreak. We used genomic data quite early in the outbreak to demonstrate that there was a number of different transmission networks. And then through the enhanced epidemiology, so looking at the epidemiology of these infections across many hospitals, we're able to link the genomic data through to the ward locations for these patients, and really highlighted the power of this genomic technology to predict where individuals, patients had been and where they're likely to have acquired their infection. I'm not going to go into the details here, except that this really does highlight the complexity of these high-risk hospital pathogens and the number of admissions that individuals had over time, and also the number of wards that they moved to. But it was a very nice example of linking the genomic data through to the epidemiological metadata to draw conclusions about the source of this outbreak in different settings. And what this led to was a statewide system for surveillance of CPE in Victoria. It's called the Search and Destroy, but in reality Search and Contain, because there'll be ongoing importations, much like we're seeing with COVID nowadays. And this was enabled by the low incidence of disease in the state, with the idea of rapidly identifying and containing CPE transmission, and really some key aspects to it, including appropriate statewide governance, the linking of metadata, that is epidemiological data, with rapid genomic investigation of all new cases. And there's been a lot of information published on this, and a lot of data that's come out showing that this system has some significant benefits in understanding the source of new cases of CPE in the state. And this is just one of those examples where over time we're still seeing KPC cases identified in Victoria, but what we're seeing is that they're mostly now colonisation. So what we're picking up through this enhanced system is cases of colonisation, but the rate of KPC disease in Victoria is dramatically reduced, suggesting that this system has had an impact on the prevalence of disease, but enhanced the acquisition of new cases through enhanced screening. So this is an example of one of the first prospective centralised CPE surveillance systems. Really accurately identifies the time and location of transmissions and enables targeted interventions. It's a resource-intensive endeavour, and there's a lot of work still to be done to understand the cost-benefit of this type of approach, but it definitely improves the understanding of the emergence of these types of diseases, and the methodology would be appropriate for the use with other low prevalence settings or organisms, and it has also been applied to Candida auris, for example. So after the success of the CPE program, there was a highly collaborative project set up in Victoria called the Melbourne Genomics Health Alliance Superbug study. And this is a prospective multi-centre study over 8 sites of about 2,800 beds, and went over 2 phases. And these are the locations of the sites here. And the idea of this was to use genomics, not for CPE, but for other high-risk hospital pathogens, and assess feasibility, impact, and optimise the communication of results, which is a really key issue around how you take quite complex laboratory genomic data and turn it into a digestible report that can be utilised at the hospital setting. And so I won't go through this in detail, except to say these are the key pathogens that were being targeted: VAN-A, VRE, MRSA, ESBL, E. coli. And there was a combination of activities, including standard laboratory activities and then centralised genomics analysis and reporting. So this is the bottom line for the results of this study. It's a 15-month period, as I said. We sequenced just over 2,200 isolates from 1,800 patients. Majority were from clinical samples, but 37% from screening samples. And you can see that the primary isolates were ESBL, E. coli, and MRSA, but also a large number of VAN-A, VRE. And so the bottom line, we learned a lot about how to interpret and report this data. I won't go into that here. But the bottom line about transmission, I think, is what is interesting. And so using international best practice approaches to determine transmission of these pathogens linked to 12 months of bed move data for each of these patients, what we found was a probable transmission of VRE, or the acquisition of VRE in the hospital was incredibly high. And you can see here, these are the categories that we determine: probable, possible, unlikely, or no relationship. And so the key message here is that 88% of VRE isolates were from patients who appeared to have acquired that while in hospital. And 35% of patients overall had acquired their MRO while in hospital. So these are quite dramatic numbers, I think. I think what's really interesting is obviously the VANA VRE incredibly high, but also we were seeing much higher proportions of hospital transmission for ESBL, E. coli and MRSA than we may have otherwise expected, 20 to 25%. And this is not really consistent with what the mindset around the acquisition of ESBL, E. coli is in Victoria at the moment, which is thought to be more of a community problem, but we were definitely demonstrating about a quarter of the cases appear to be acquired in hospital. And so where did this transmission occur? High-risk wards were definitely an issue for VANA, VRE and MRSA, but actually 50% of the transmissions that we were detecting were occurring in general and subacute care wards. So these are not usually considered high risk. And this really has implications for infection control in these settings. And of the probable transmission, 64% of them occurred in a ward prior to the site of where the sample was sent to the laboratory. That is, that most of these were occurring in previous wards or previous admissions, making it critical to overlay epidemiological data and patient movement data to accurately interpret the genomics. And so some of the successes therefore are really being able to detect occult transmission in 80 wards, really changing the focus on the sites and the species to focus on in terms of the risk of transmission in hospitals. Particularly the fact that ESBL, E. coli and MRSA were commonly being transmitted. It was very useful for outbreak investigations. And I think the other thing that was interesting, it allowed comparison between hospital sites such that you could look at transmission rates, for example, for VRE by occupied bed day or another measure of transmission per admission. And this really led particularly one institution to refocus their efforts on VANA, VRE and altered their practices around controlling this. And it has also contributed, given the number of transmissions that appear to be occurring in these hospitals, planned changes in statewide notifiable diseases in Victoria. So that's a couple of key hospital pathogen projects that we've done that have informed our thinking around that. I guess before I moved on to a bit more of a global overview, I just wanted to briefly talk about validation of genomic data workflows for AMR. And here I've got two key steps. One is the concept around taking genomic data, the raw reads, using some sort of gene or mutation database and generating a report around what resistant elements are present in that bacterial species and how that might inform treatment or surveillance. And the second is around how, like I mentioned earlier, you compare genomes to each other to generate phylogenetic relationships, showing, for example, that these samples all look the same and therefore are much more likely to have been spread between patients than, for example, one up here and one down here. And these are two different processes that require very different steps, but both of them are really critical. If you want to take pathogen genomics to the public health or clinical interface, you need to have processes for ensuring standardization and accreditation of these two steps. And that's because, based on this data, there may be suggestions to close wards and even at some points closing parts of a hospital. And so you want to know that what the data you are generating is reproducible and will stand up in a court of law. And here, if you're trying to detect resistant elements and you're going to change the treatment that you're going to give a patient based on that, then you really need to know that you're doing that in a very highly standardized way that NATA and other accrediting bodies will find acceptable. And why is this not straightforward? Well, because a lot of the tools that we use to do this surveillance and to look at genomic data are developed in the research environment, and they don't really have that clinical or public health or accreditation overlay to them. And so we really require robust approaches to doing this. So this is an example of why it's complex. So this is the database that we use, which is the database that comes from the NCBI, which is the AMR Finder database. And this is the type of output you get when you screen your genome. So you might have an allele type, a product name, and then some sort of link to an antibiotic class or subclass. and there's over 5,000 of these genes present in this database, but it's not clearly linked to a potential resistance phenotype. And so Narelle Sherry, who works in our lab, spent a lot of time putting this enhanced subclass categorization into over 5,000 resistance genes that are present in this AMR Finder database, allowing us to go from here, the detection of the gene, through to a clinically meaningful output. And so what we've done is develop an approach called Abratamer, which takes the genomic data, assembles it, runs it through an internal program to perform a protein-protein an analysis for the presence of resistance elements, and then looks at the genes and passes them by functional groups, and then looks at which of these genes are reportable or not reportable by species. And so for every bacterial species, you need some sort of reporting logic to understand whether the element that's been detected is of relevance and needs to be reported or not. And so this was a huge amount of work to do this, but once it's embedded, it allows quite sophisticated analysis and reporting to be undertaken. And just quickly, so what do? You know, often with genomic data, you may not get exact matches. And so this is the approach we've come up with, where if you've got an exact match and it's completely, you've got complete coverage of that gene in the genome, you're reported as detected. If it's close, so greater than 90%, but not 100%, we'll say, yes, it's detected, but it has an asterisk and a comment. And if it's partial, then it won't be reported. And what about the phylogenetics then? So it's a completely different process. This is about detecting SNPs. So how do you find mutations in the data, infer a phylogenetic tree, and then demonstrate that the clustering approach you have works? And this is about linking genomic data with well-curated epidemiological data to show that every time that you have a well-curated epidemiological outbreak, you are able to detect that through your genomic interpretation approaches. This is very different to detecting an AMR gene or resistance mutation, but an important step if you're going to look at potential outbreaks of AMR pathogens. So what does that allow us to do? This is an example of a recent report we've generated where there was quite a complex infection with a Mycoplasma hominis, an unusual, not something you necessarily immediately think of as something requiring an AMR detection genotype to be undertaken, but this was a patient that was going to require months and months of antimicrobial therapy. The susceptibility testing in the lab was difficult, and there was a suggestion there might be tetracycline resistance, but it wasn't confirmed. And so using this approach of sequencing the genome, comparing it to the reference database, and generating a validated report, we're able to say, yes, the TET-M gene is present and it will likely be tetracycline resistance. No fluoroquinolone resistant mutations were detected, likely to be ciprofloxacin susceptible, and there were mutations at loci that have been linked to macrolide resistance, again suggesting that macrolides may not be the best choice. And so it's an interesting demonstration of how you can take this type of AMR detection data and link it back to personalised therapeutic approaches in patients. So just another quick case study now. There's just got a couple more, but one thing that we do hear a lot about is One Health AMR, and also the use of integrated genomic data for One Health. There's definitely some significant opportunities here, but not necessarily a lot of successes to date. There are some WHO programs looking at linking ESBL, E. coli through the One Health spectrum in Asia called the Tricycle Project, and some other emerging projects. But this ability to link human and non-human genomic data for drug-resistant pathogens is really important. And this is just a small example out of Victoria again, where we had an outbreak of ESBL salmonella in humans in Victoria, and at the same time started to see similar samples coming through the laboratory from bovine sources in the state, and these are just mapped to the map there. And because our laboratory works with both human and non-human samples, there's the opportunity to integrate that data, and the genomics here shows that there's a very clonal outbreak of drug-resistant or ESBL positive salmonellas that are present both in bovine in the light blue and human in purple cases here. And so it's just a small but nice example of how the linking of the genomic data across human and non-human sources allows a better understanding of drug-resistant movement between humans and animals or the environment, and how this led to an investigation of the potential source and then the disruption of that source. And so there's huge opportunities in future to really enhance this approach to this One Health genomics AMR agenda. And what about, I've talked a bit about hospital AMR, what about community AMR? Again, just another small case study out of Victoria that we've recently looked at, where we had Shigella sonii, a significant increase in the number of ESBL positive cases coming through our laboratory. So all Shigellas in Victoria are referred to our laboratory for confirmation and testing. And we just started to see an increase in ESBL positive Shigellas. And when you look at the genomic data, again, this was an outbreak of a very clonal Shigella sonii that had an ESBL, that had mutations leading to reduced quinolone susceptibility, macrolide mutations, and also Bactrim resistance. And so a very drug-resistant Shigella spreading in the community, predominantly in the young male population. And this is most likely a sexually transmitted Shigella outbreak that's been going on in Victoria for the last 12 months or so, and really demonstrates the importance of this type of technology to look at potential sources of emerging AMR disease and how we might think about intervening to reduce their spread. And finally, just a couple of slides on the global perspective before I wrap up. This is just to highlight that the WHO is interested in the concept of whole genome sequencing for surveillance of AMR. This is a document that was released, I think, last month, and really just goes through a number of advantages and limitations of the technology, some of the requirements for implementation around the world, and really also highlights the issue of data collection, sharing and storage, and how that might advance the idea of linking genomics to other AMR surveillance activities through the GLASS system. And so that's well worth a read if you're interested in that topic. And how has this been applied? Well, this is a nice example. It's just come out in Nature Communications from the Philippines, where they've linked up with a genomic laboratory in the UK, showing how you link sentinel surveillance site phenotypes through to genomic data and then back through to WHONet and sort of coordinated reports on what is happening in the country. So I'm not going to go through all the detail here, but just to give a brief example of what this allows the Philippines to now do. They have sites around the country where they have epiphenotype and genomic data. And this is just an example for Klebsiella pneumoniae, CPE, where they've found a particular clone with a number of different resistance elements. And they're now able to map back to where these elements are present around the country, what the resistance genotype is, and how the strains are related to each other. And this can really inform ideas about the emergence of new resistant clones and possibly lead to either improvements in the prevention of further emergence of resistance, or also improvements in empiric treatment guidelines or response to therapeutic interventions for sick patients in these regions, once you have a better understanding of the genomic epidemiology across the country. So it's a good example of how you might how you implement this technology to drive understanding and response to AMR in a country. And then finally, what's happening in Australia in terms of I guess public health pathogen genomics and how this might fit into a AMR genomic response. We now have a national microbial genomics framework in Australia. It was published last year and lays out the groundwork for standardisation of national approaches for AMR genomics, what the technology and data governance should be, how we best integrate genomics into public health in Australia, and also a bit about access and workforce, which is a big requirement. There's also this Communicable Diseases Genomics Network, which represents the public health labs around the country and in New Zealand who work collaboratively on public health pathogen genomics. It sits under PHLN and AHPPC, and has recently developed a governance structure and a platform called AusTracker that allows the sharing and comparison of genomic data around the country. And this has been initially focused on COVID, obviously, given the recent pandemic. but we'll be able to transition to exploring other public health pathogens at the AMR interface. And this will be further supported by this quite large Precision Public Health in Australia Pathogen Genomics project, which is recently funded by the MRFF for 3 years. This project is looking at primarily public health pathogens, integrating data around the country using genomics, and then thinking about optimal models for linking epidemiological data to the genomic data and then evaluating the impact. But as I mentioned at the start, given that AMR is a key issue in a number of these important public health pathogens, there's an opportunity to explore how this integration can lead to a better understanding and response to AMR in Australia, but also keeping in mind that we live in obviously a global environment where the movement of AMR in our region and around the world is also very important to understand. So not just focusing in Australia, but being cognizant of international context. So just to summarise at the end then, so what are the opportunities of using genomics for AMR? I mentioned at the start this idea of the genomics-enabled diagnostic lab or a linked reference lab working at the hospital ward or individual level, and then the systems approach, which is a bit more at the state, national or international level. And so this type of work will focus on personalised AMR genomics. How do you use it to treat individual patients and better optimise therapeutics, and also thinking about hospital infection control issues. Whereas through the public health system, we will be thinking more about systematic AMR surveillance and response, how AMR is emerging, spreading, and how we might optimise control, and also better understanding the opportunities for a One Health genomics-based AMR approach to understanding the problem. I think underpinning this is really critically is accreditation and standardisation. We can't change therapy in patients without an accredited laboratory approach. And then if we want to share data across different sites and around the world, then we need standardisation of approaches, and really critically important is rapid and appropriate data sharing governance to really enhance our understanding of this problem. So I'm not going to, I can't thank individuals because it's actually a massive team of people that have contributed to this type of work over the last 5 to 10 years. But I will thank all of the labs that are part of the Communicable Diseases Genomics Network. I'll particularly thank people who work in my lab and have done a lot of work on validating genomic approaches for AMR, and also the development of AUSTRACKER, and then funding through Australian Government, MRFF and NHMRC, and also the Victorian Government. Thanks very much.
Thanks, Ben. That was absolutely wonderful. We're not going to have questions and answers as part of this session, but we will be opening out for questions and answers through the subsequent sessions over this week. So please feel free. We'll make sure that the chat function is available for you. So thank you to all our speakers. Particularly grateful that Paul Kelly and Mark Schipp were able to open up our first day today. I look forward to the rest of the week. As I said before, every session will be recorded and put onto the NCAS website. And feel free to contact any of our team if you'd like any additional information or assistance with your own research or clinical issues around this. So thanks everyone, and enjoy the rest of the week.